Good morning. On behalf of my colleagues here, I, I, I thought let's set the ball rolling for this year's RESPICON. We had some fantastic workshops yesterday. And today's session, as you know, is more about an informal interaction without a format with experts. So we have with us Dr. Naga, Bhushan, Dr. Sadashivam, and I'm sure there would be several questions you have around that, but it may be maybe a quick round of introduction. I am Dr. Varinder Singh from Lady Hardinge Medical College, Delhi.
I'm Dr. Sadashivam Suresh, Pediatric Respiratory and Sleep Physician from Queensland Children's Hospital, Brisbane, Australia.
Dr. Bhushan from Bangalore.
Right. So I don't know why I picked up the mic first, but first of all, let me remind this audience, we are supposed to be the expert and you are supposed to be asking us some questions, because I see only the experts on that side and this side as well. So who is an expert? Let's start with that. Who is an expert? To me, an expert is that who has made a lot of mistakes in life and then learned from it. And then desires to share those follies with others so that they do not rediscover the wheel or make the same mistakes. So that's the definition of expert as far as I know. Nagabhushan, what about you?
An expert is one who can reach the hall at 8 a.m. in the morning.
That's a good one. And what do you think, Dr. Suresh?
I think it's always very difficult when you call yourself the expert and you are in a subspecialty conference wherein you are surrounded by experts.
Yeah.
And then you have to really look at your dictionary and say, please define imposter syndrome. You are sitting here and there are a lot more learned people around there as well. So that's the personal reflection. But when you look at what an expert is, it is the culmination of a particular stage of your journey, but somebody who knows the journey is not finished. And that is, so you don't get there without blood and sweat, but just getting there, you don't stay there. It is like a downward going escalator. You need to continuously do at least basic effort to stay where you are. And if you are inspired, you can climb against the downgoing escalator and climb up the ladder.
So if there are any questions by anyone, I see some young people here. Any questions you have thought of? Or we can start with what is a question?
The youngsters could start. We see quite a few youngsters here.
So one of the questions which very often is in our mind and we find it difficult to articulate, I found it very difficult to articulate when I was a young one, was that you were in awe of the people who were there on the other side and you always thought, well, I want to be there one day, but I don't know how. One thing Dr. Suresh said, it's a lot of blood and sweat. Of course it is. But blood and sweat where? Jumping, somebody jumping on one place just to stay there is not blood and sweat. It has to move, it has to be in the right direction. So youngsters here, what kind of opportunities they can think of training in Australia? What is the usual process?
It's been quite complicated recently, but I'm looking at how differently we can work with it. So in the past, this is pre-COVID I'm talking, in the past, if you had a reasonably detailed postgraduate experience here and you were able to get a sponsor who can give you a 1-year or a 2-year fellowship, it was quite easy to come through the system and do the training opportunity. However, around COVID time and also the visa restriction time, people have made certain changes to it. So at this point in time, I would say it's fluid, but having spoken to a couple of my UK colleagues here, I'm really inspired to go back and see if I can do the UK model and try and link up with people in this organizing committee, etc., to see whether we can get people across. So you have to psychologically think this mathematics. It's a vast country, but the population is 26 million. Okay? 26 million with a pediatric population that is very small. There is only so much medicine you can do. You can't create diseases. So the demand is very limited at a subspecialty level. So what we struggle with is not to overtrain locals so that we don't give them training without a job at the end. So what I am thinking, this is thinking loud, probably nobody should quote me on this, is by creating this collaboration, it's a win-win. We will not do an oversupply locally. At the same time, we will be able to train people where there is value for training added.
Yeah. So UK used to have this model. I'm not to date on that, but they had this overseas training scheme under which you were mandatorily required to go back to your parent country after 3 years of training. So
I think it's a little bit different in Australia. They don't make all those things. They just basically say it's a workforce thing. So if you need somebody to come, give them a job. And the Australian training system regulates that you need to go through their training system 5-6 years before they would give any equivalence. So just because you have got enough of credibility there, you go through the overseas training program, and they may still make you do extra X number of years if you want to stay back in the country. So I'm not talking about that. I'm talking more about how do we harness collaboration? And your first question is, what are the training opportunities? So the training opportunities is, we have a very extensive, I'm talking about respiratory and sleep medicine, and probably sleep medicine is very, very advanced in our country for historical reasons, and innovation happened in the 1980s. And it gives a great opportunity for people to come and train, and they can get the expertise, which is quite hard to get even in UK for that matter. In respiratory medicine, we have a very strong research focus, and we have very extremely skilled bronchoscopy service that we do. And so complex respiratory is still complex respiratory everywhere, so you get to learn about a lot of things. So I think there's enough for a trainee or even a qualified consultant to come and get top-up experience for 12 to 24 months. My job is to go back and find out how.
Yeah, Ramesh? So Dr. Mahesh is at Singapore. Please, Mahesh, please carry on. Mike?
Just to kickstart things on the clinical side of things, what do you all think is the role for guidelines? Because there are a lot of confusion with so many guidelines. For example, let's just concentrate on asthma. People think of GINA guidelines as the 10 commandments sent by God. But there are 10 other commandments which are given by 10 different group of people as well. So I want to know from some of your experts, how do you view international guidelines? And how do you incorporate it in your everyday life? Where do you choose to follow them? Where do you choose to break them? And how do you do it as an expert?
Thanks, Mahesh. This has been a question on which we debated in the RESPICON Pune. And that was a time when the single anti-inflammatory inhaler had come into existence. See, as far as I look at the guidelines and the paradigm changes that happen in the guidelines, the first reaction of any astute and well-read pediatrician is whether to believe it or not to. The reason being, to quote it very simply, we were told and we understood that inhaled steroids take quite some time to act. And we were telling our delegates that it would take around 15 days, only then you will expect a response. And there comes a situation where you say you use inhaled steroids as and when necessary, as many times as possible, and it still works. So these were situations where at that point in time, we did not know whether to perpetuate this. There were two issues here. Issue one was to break the belief of what we had taught for quite some time. And issue two was to re-educate ourselves and re-educate our own colleagues about these issues. And that took quite some time. The other issue about guidelines, which most of us believe, is that instead of blindly accepting the guidelines from international societies, I'm sure they would have done enough work and research on the issue before they publish it, but question ourselves to find out whether these guidelines suit my situation and the children whom we treat. I think there should be an introspection, there should be a debate before we blindly accept these guidelines into our situation. The third issue, now if you look at the anti-inflammatory single-use medication that we have, GINA guidelines uses it both for relieving as well as controlling. But if you look at the NAEP guidelines, it uses it only in stage 3. Why have they not used it here? So these are a few points that come to my mind, so that I think we need to churn these issues out before we accept it as gospel truth. In the conference in Pune, there were about 4 or 5 studies only before this thing came up as a guideline. So should we believe only 5 or 6? Is it enough for us to change our practice? These are issues that we need to deliberate.
I think one of the constraints we have is we have a lot of patients, but no data. We have a lot of patients, but we do not have structured studies done here. On one hand, one could be cynical and say, okay, this is an international guideline and it has been imposed upon us. Why? That kind of xenophobia for a modern medicine is perhaps not correct. At the same time, I would go back to Gandhi. Let the wind of all nations flow through my house, but not blow me off my feet. I'm paraphrasing it, it's not the exact word. So I think the guideline development has three very important components or 3 different stages. So even WHO talks of it as a concept of development, where they say you can either adopt as they exist or adapt of what is suitable to you or develop. So it's not one kind of thing, because one must realize we are a nation which is contradictory or heterogeneous in several ways. We are an LMIC, we are an aspiring nation which is growing at a rapid pace. We are in some stages almost there where the other people are, but that's very patchy, and it's an apex of pyramid where you can claim that you are anywhere closer to the developed societies. Mostly you are at the lower part of the pyramid. So when it comes to health science, I mean, look at this venue. Is it any short of any European or American venue? No. But is it India? So when we talk of diseases, when we talk of where these patients will get treated, so guidelines suited to whom? To the nation is a harder part. Where there is no structure of guideline is useful if there is a way to implement it. Either a self-implementation through training, guidance, or through legislation, or through peer pressures, or maybe taught, whatever. So that's another bigger animal in the room, which we often do not talk of. So coming back to a very specific answer to your question, I would say one has to really look at the evidence based on which any international guideline comes. Now, the recent SMART and MART move, I think it was very smart. One product which is not even used in India, a particular combination, a particular device. Why do we forget science? Just because Gina said it. Is MDI with spacer same thing as a DPI? Can they be equated? Are there enough studies to say that? So what is the clinching evidence is one important. The second thing is the context of that. What's hurting our society? They have a different kind of setup, a different proportion of patients with atopy, and it may be, their studies have shown the mortality in our population is more because people are not taking regular drugs. So if I give an extra LABA here, maybe I'll get a better control. So those are the parameters they are looking at. Whereas what we have been struggling, the previous decade was a struggle about people identifying the stages of asthma early enough to start steroids. Then the pendulum took a swing. We are giving everybody a steroid. Any child who started coughing got a nebulizer, and now nebulizer is a household cough medicine. So we have taken another swing. So guidance has to be contextualized, and bodies like NRC, which are working very hard, creating more and more evidence-based guidelines as possible, but then they get limited by the evidence created elsewhere, not in-house. So with those deficiencies, having an idea to adapt is fine, or adapt is fine, but how far it can be adapted in absence of local evidence becomes a challenge. So you come down to the lowest form of evidence base, where it is more about expert opinion, mine against yours. And then we do know some expert opinions do get colored by things beyond science. So that's the harder part. But bottom line will be, we should not adopt all the guidelines which come our way. We must in great detail and great diligence look at the evidence which is being produced. At least try to understand the context of the study and not just merely read the outcome. We only look at the result part, 2 tables, and at best maybe who wrote it. While there is more into detail as to where it started from, or what was the methodology before we come to what the results were.
Thank you. Thank you. I appreciate it. Thank you. And I think that's exactly what happens in a community level, right? Because we are talking about lack of data in our own country to form our own guidelines in many situations for the reasons that you all said. At the same time, there's a pressure on the pediatricians to kind of think and feel they have followed the international guidelines without understanding the limitations of what it is to their particular way of doing things. Thank you. I will open it up to any other questions.
Can I add?
Yes.
There are 2 other issues which haunt us. Those of us who have been seeing children with asthma in our country in the last 3.5 decades do not feel comfortable to the fact that this frequent use of salbutamol can cause acute severe flare-ups even in the so-called mild asthmatics. That has not been our experience. The other statement about frequent use causing sudden deaths in asthmatic children is also not the experience of most of us. So are we dealing with a disease which has got a different severity in our population as compared to a disease from the West is something that we will have to think, because the statements are maybe true to the international setup. Then we would have had a lot of asthma deaths in our country, which at least to our experience has not been there. Looking at the way people are using salbutamol day in and day out. The other issue that should bother us as a developing country is the cost of therapy. And the combination therapy is definitely much more expensive as compared to the treatment that we were giving a little earlier. So these are two other issues that we need to dwell when a new guideline comes. Does it suit us? Is a question that we need to ask.
I'm Dr. Suresh Babu from Karnataka. This is question to Varinder. This is basically a problem which we come across in our clinical practice, as we are an expert in tuberculosis. This is a basic question, sir. We have many times a child who is coming with fever frequently, and there is a doubtful exposure of this child for an adult tuberculosis, and we investigate this child, we do gene expert, but nothing comes out. X-ray is normal. Sometimes PPD may be borderline. So, and the child is continuously having a clinical problem, like continuous fever, failing to thrive. Under these situations, the guideline says you have to prove the diagnosis by demonstrating the tuberculosis bacilli. And we send these children for the NRTCP, but they refuse to give medications for these children, especially childhood. So what are the exact advice which we have to give to these patients, and how we have to move about this?
Thank you, sir, for that question. I think you need to interact with your NTE people more if they are refusing such patients, because they can't. The national algorithm very clearly says, which we have adopted both by IAP and the national program, it does give a lot of weightage to a molecular diagnosis or an early bacillary diagnosis, because now the philosophy has changed from diagnosis of TB to diagnosis of TB with its RIF sensitivity, because the implication of MDR TB increase if we first give first line and delay and then look at failures and then do treatment, it hurts the individual as well as the community. That's the idea. And yes, children are usually not infectious, but this concept that children are never infectious is wrong. Children can be as infectious as adults, particularly the adolescents or those with the cavitary disease or a pneumonia. So therefore, the paradigm, our understanding, there is nothing called as a childhood TB. TB is either primary or post-primary. It happens more often in children that they have primary disease, but not children do not only have primary. And when, as an academy, we deal up to 18 years, we are not talking of one population. We're not talking of only under 5. So when we made that algorithm, we were very clear in our head. The newer methods have a sensitivity which is not, it is much better than smear, but still not what you or I would have liked. It's about 60% or 70% of total pediatric, and when you come down to maybe a primary TB, it will be around 25-30%. So there would be a large chunk of patients who would be negative by this. The insistence is, you see, any guideline has two things. One is it has to start a new area or a new direction to how you diagnose, how you treat. The second important part is it has to break old habits. So you first have to, one has to first de-learn what one has been practicing and adapt what is right now, because that's the changing science. So emphasis on the molecular diagnosis or on gastric aspirates was because earlier smears were so less positive that there was a kind of, we had left doing gastric aspirates, we have stopped doing any microbiological testing on TB. So emphasis is merely that now there is a better test and it gives us more information. But it does recognize that there would be patients like the one you are referring to, which may be either that you have a shadow and you have a fever, which keeps it open, it's not necessarily TB, then it must be more intensively worked at. One of the reasons why TB samples are negative are the quality of specimen is poor. It is not the test. Now, how we are primarily an excreta hating society. Ba and Bapu fought with each other on cleaning their own toilets. So we follow that kind of culture. We spit around everywhere, but we hate it. So when it comes to gastric aspirate or a stool collection or a urine collection, it is left to the intern who has never been taught how to collect it, or a sputum. So we tell the patient, isme kuch balgam nikal ke dena. What is their understanding of that balgam? Do they understand what sputum is? I'm sorry, I'm going to very basics. But our studies have shown that because of these pre-test pre-test elements not being in place, a good test fails. So once you have such a situation, I'm sure when you are saying, taking up this question, you looked after this pre-test elements as much, but for the wider audience, I was making that comment. If then it comes negative, then the imperative on you is, as a clinician, have you ruled out alternative causes for that fever or for that shadow adequately enough? Whether it is an invasive method or a ball or whatever, what is possible in your setting. Once you have done that, then there is a category called clinically diagnosed, clinico-radiologically diagnosed TB. And that has to be treated, and it is there under the program. If your NTB people are refusing to treat these, they can be taken to task. It is there in there.
Dr. Satish Pandya from Baroda. Dr. Naga, Bhushan, while answering the question about following guidelines, you raised two important issues regarding asthma. You said the severity of asthma is not as much as what they report in Western world. I want to ask a question to all the experts here that over a period of 3 or 4 decades, in my practice at least, I have seen the increasing number of patients who are difficult to treat or not well controlled. So what is your experience? Another issue which you raised was about efficacy of MART therapy. I've been using it for last couple of years now, and I find it very useful. I mean, this is a personal observation, so I want comments from the experts on the dais and from the audience front. You didn't hear, sir?
What have you been using?
MART therapy.
MART. That you mentioned about MART, whether it is suitable for our country or not.
Now, to answer your
MART with an inhaler. And I completely second what Dr. Pandya is saying. We have been seeing increasing number of cases which are difficult to treat. And I have been using smart therapy as an inhaler, not as an DPI. And I'm finding really good results with that. So we definitely want experts' comments.
Now, to answer your first question, now when I said severity, specifically I meant the relationship between frequent use of SABA and the adverse effects. That was something that we had not really observed. The second issue about increasing children with increasing difficult to control asthma. It's possible because we are looking at a generation of children now who are different from the generation of children earlier. Particularly this has happened to us during and after COVID. The reasons that we thought are relevant are, number one, lifestyle changes have been significant. Children get up at 12 in the afternoon and sleep at 3 a.m. in the morning. There has been a significant increase in the quantity of foods which is not prepared at home. That's a second issue. The third issue is children don't play as well these days as compared to the time 20 years ago for many reasons. And number four, behavioral issues have added on to clinical management. It's not only in asthma, it's in any other disease. And therefore, all these factors, and the fifth and the most important factor is obesity. We are seeing a good number of obese children these days as compared to earlier, and it is very difficult to convince parents that their children are overweight. And all these factors could have contributed to difficult to treat asthma. And to add on to that, working parents. And when both parents work, both parents come home late, compliance becomes an issue with therapy.
I was wondering, you also have a lot of aboriginals and relatively not so well-off population. Do they, I've never been to Australia, so I have no idea how far they mimic Indian situations or whether they mimic at all. But would you find that there is a different kind of disease or disease pattern in the context of asthma, or
It's been for lack of a better word, it's been quite boring in Australia at the moment with asthma. We have not had any significant spikes or any nasty turns, etc., to that effect. And quite a lot of understanding through birth cohort studies, and we are trying to figure out, have we made any structural changes very early on in life that has impacted the period prevalence of this across the criteria? We don't know the answer to that. But what I have noticed is, at least in the last 4 or 5 years, there has been significant change in what the guidelines say, etc. But the severity profile of patients has not significantly changed. So to me, all this extra debate that is going around the maintenance and reliever therapy, and whether you give it using the budesonide combined with efformetrol, or the risk about giving too much short-acting beta agonist. We do notice children who are not on some form of preventive therapy do have an increased morbidity. But the morbidity is at a lower level, missed school, missed etc., but not in the going to ICU level, etc. So the epidemiology of flare-ups, especially in the last 18 months, has significantly changed post-COVID. So we had one of the draconian quarantine systems wherein even states didn't allow people to move between each other. And we had extraordinarily low morbidity through those 2 years that when we did that. But since then, even a rhinovirus or a human metapneumovirus is putting some of these children in hospital, which would not have happened previously. And I think people are seriously looking at the what we took for granted, that this is all well controlled. There is only a very small portion of very severe people who are highly atopic, who have got high eosinophilic inflammation, who need MABs, the monoclonal antibodies. Other than that, you can basically... So our clinic don't get to see many of these patients. We only get the complex asthma. So to me, I can't speak from direct experience because of the way the primary care is structured. Answering your second question about the indigenous population and their multimorbidity, etc. Yes, we have a very poor health indices for that population. We are working hard on that group. And it is interesting to note, it's more their infection and protracted bronchitis and bronchiectasis is a bigger morbidity than the asthma or the reactive airways. So I've not answered the question, but I've just given you an epidemiological walkthrough of what is prevailing in that space. And it is very interesting for me to reflect on your journey. And I just want to answer Mahesh's question about guidelines. Just one point about it. It is really important as a national body that we need to make a statement about this, because in this fast-moving world of news and somebody else says this and somebody else says that, anybody who has got the gift of the gab and who can have a YouTube channel can perpetuate a lot more rubbish if your national body does not stand up and say something. So that is the only request I'll put.
Yeah, a good point. So coming back to what you asked, I am sorry if I am making a comment out of context or it looks harsh, but most of us experts, I know you are a very experienced pediatrician and could have been on this side of the table as much. So we always suffer from a recall bias. We are talking of a change of guideline for every child. Do you think this proportion, which is benefiting for SMART, is the largest set of patients you are seeing in your practice? Here it is saying even at stage 1, start with it. is that justified? Is there enough to say, enough data to say? We have already, in the global world, we have gone around a full 360-degree circle. We started with no steroids when I was a resident, to a steroid being the drug, to steroid being able to prevent an early changes in the airway, to no, it can only control symptoms and perhaps retard it, to again adding it for mild. So where are the earlier lessons which we learned? Has the science evolved? Has it given us something more new to say, no, that scientific truth, half-life is over, new thing has come. So this particular recommendation doesn't give us any data on those. We have no new data points on those issues. We only have a contextual information on a limited group, and we're trying to generalize it. So my problem is only with that generalization. I have no debate around using MART or SMART for a smaller set of patients. My question is more wider about using for every patient. It is like when Ipravent was first recognized, the combination of Ipravent salbutamol became the primary drug for any child who walked into any OPD with coughing. No, forget even asthma, even today. Am I right? So where are we headed if we start doing SMART for every child in this country, where just because it's there, then anybody can decide it is right? So there has to be, our adaptation has to be in context of, even if you have to create another stage within what Gina says, create it, no problem. Poorly controlled, this is it, this kind of behavior, this is the high-risk population, it's okay if you use SMART. Put an asterisk and say, but making a sweeping statement for the whole country and all set of asthma, I see a kind of a little overzealous and a pushy approach here, which may not necessarily be right. So anyway, any other question?
Could I add?
Yeah.
To answer your question, adolescence is a situation in life where there are many risks, personal, social and environmental. And as Professor Varinder Singh rightly said, every child may not need the benefit of anti-inflammatory reliever therapy. There could be an adolescent who says, I will take only one inhaler, I will not take two. So probably the situation matches him or her. The other problem or the other musing, I would say, is that earlier we were saying give it regularly, twice a day, religiously. And now we have come to the stage to say that you give it as and when necessary, but still 67% of the time the patient gets better. So these are principles that don't match. And my personal experience with the use of single inhaler is not very great for me to share that with you. But as Professor Varinder said, we need to look back to see whether we have to apply this to everyone under our care.
Yes, sir. I am Dr. Rawat from Indore. Since past couple of months, rather, we have been seeing a lot of severe viral infection of lower respiratory tract. And we have been diagnosing a condition known as post-infectious bronchiolitis obliterans now more often. So what is the current status of management of these children and what is the long-term outcome? Because there is not much data regarding management of these severe viral LRTs, particularly PIBOs. So what is the current status? How do you manage them the best way and what is the long-term outcome?
So PIBO, yes, we are seeing more, I would say, but I would not say there is an epidemic. We have a fairly busy practice. Where I work, we have about 50 to 60 admission a day, of which about 30% are respiratory, just to give a context. Okay. So how many PIBO I have diagnosed in last 1 year? I have diagnosed 4 or maybe 5. Because I was not anticipating these questions, I may be off by a couple of figure here or there. Not more than 4 or 5. So what is that? When the awareness of something increases, you already have patients who are suffering for years, who have not been recognized. So whenever a new diagnosis will come, initially you will see a spurt for 2 reasons. inexperience of people who make the diagnosis, so they put a label everywhere, it becomes fashionable. Second is, there is, in a large country like ours, there were a lot who were looking for that label which was not given for lack of knowledge. So gradually you will find that, okay, this is there but not as much. Now coming to the second part of your question, yes, it is there. Our understanding about increase in viral illness, or whether there is actually an increase in viral illnesses, with shift, there is an opportunity cost. When we talk of sickness, it's host, environment and agent. More and more vaccination of pneumococcus, H flu, you will have more and more viral infections coming up. They are always competing. And secondly, thanks to biofire and everything, we now more often know they are viral. Earlier, everything was given an antibiotic. WHO told us if there is tachypnea, treat as pneumonia. That was okay for 70s, but even today we are told treat every tachypnea with antibiotic. This is rubbish, right? But coming back to the second part of your question, which is on bronchiolitis obliterans, there are no RCTs on this. Most of the literature comes from Brazil and the South American, Latin, and our own experiences. We use a lot of pulse steroids with them, and sometimes you have even to add initial periods along with that oral steroids. We do give them other anti-inflammatories and like hydroxychloroquine, that's what we use. They also have a lot of time clearance problems, and quite often they would require not only LABA, even LAMA to control their symptoms. And they're a very tricky sphere. Quite often when you make a late diagnosis, they also have cor pulmonale, and therefore till you address that increased pulmonary artery hypertension, though ideally if it is secondary increased, you have to deal with the disease, the cause of it. But often it goes overboard. Temporarily you also have to work on those, identify those patients who also have severe PH despite controlling their symptoms, giving all your, to add that to the background. So I can't give you a singular prescription, it needs to be individualized. There are no very clear guidelines on this. Do you have anything to add?
No, I think we are watching that space. There is a suspicion post-COVID, some of the severe viral illnesses will have the sequelae there, and so there is no standardized treatment. It's very experience-based. I've seen one kid, this is how I treat it. Pulse steroids is quite commonly used. Sometimes there is always adding in of an inhaled steroid with azithromycin and montelukast. There is some published literature on that. And some of the children that we have, at least I've probably followed up 3 in my last 13 years, my patients that I know their journey. The hit is there. You treat initially with the pulse steroids. Whatever you have lost, you have lost. But fortunately, we keep an eye on the pulmonary hypertension and all side of things. It has not eventuated. But I know of 2 or 3 kids who have went on to progress very badly and end up in a bad shape. So I think it's a very different condition. But at least a couple of my intensive care colleagues have interest in some inflammatory work, and they are worried this spate of viruses post-COVID, we need to look at that. So they are prospectively following up these inflammatory markers in these children.
One of the troubles with
Thank you,
COVID
sir. Sir, I think the time's up, so can we discuss after the session, during lunch?
Thank you.
Can you
During
give us
the
2
break.
minutes just to finish?
Okay.
Thank you. We started 20 minutes late. So just to finish this last question, I totally agree with, that's what we use, azithromycin as an anti-inflammatory thrice a week. In addition, quite often they have associated GR. And GR also is sometimes what leads to headed injury and PIBO. So they cause or effect is hard to say, but because of the flattening, then they have this additional issue. The difficulty which I find with COVID-related diseases is, in our country, most countries had it, but we had such a rampant spread that if you do COVID antibodies of children, whether vaccinated or not, you will get them positive in 70-80%. And then saying that anything which happens thereafter has a relationship with COVID is so hard.
It was not that, sorry. It was not that. It is not related to COVID kind of thing. What we are thinking of is the virulence and the host response to other viruses has been modified. Not because of COVID, but because of the...
It could have been modified.
Modified.
So maybe that's why we reacted differently to COVID. Okay, that's an interesting thought. Thank you. Thank you, Pallab. We are done.